Welcome to our monthly webinar series hosted by the Office of Integrated Healthcare Research and Policy in the Department of Family Medicine at the University of Colorado School of Medicine. Let me begin by telling you a bit about our sponsors and partners. This webinar series is sponsored by the California Mental Health Services Authority Integrated Behavioral Health Project. CalMESA is an organization of county governments working to improve mental health outcomes for individuals, families, and communities. Prevention and early intervention programs implemented by CalMESA are funded by counties through voter-approved Proposition 63, the Mental Health Services Act. Prop 63 provides the funding framework needed to expand mental health services to previously underserved populations and all of California's diverse communities. The Agency for Healthcare Research and Quality, Academy for Integrating Behavioral Health and Primary Care, functions as a coordinating center and national resource for people committed to delivering comprehensive integrated healthcare. The Academy focuses particularly on integrating behavioral health care into primary care practices and promotes a collaborative environment that fosters dialogue among leaders and other stakeholders in integrated behavioral health and primary care. Key Academy tasks include the National Integration Academy Council of Expert Panel of nationally recognized leaders in integrated healthcare, the Academy web portal and literature repository where there are over 1,900 citations, and the recently developed lexicon for behavioral health and primary care integration, and much more. The Collaborative Family Healthcare Association is a nonprofit, member-driven, collaborative organization in existence since 1995. CFHA promotes a comprehensive and cost-effective model of healthcare delivery that integrates mind and body, individuals and families, patients, providers, and communities. Advancing Care Together, a project of University of Colorado Denver Department of Family Medicine, is a 4-year program aimed to discover practical models to integrate mental health, substance use, and primary care services. The program, funded by the Colorado Health Foundation, has funded 11 demonstration projects that have been organized as a set of diverse comparative case studies and will be linked to support cross-project learning. Before introducing Dr. Michael Hogan, I would like to go over a few housekeeping items for GoToWebinar. On the right hand of your screen is your GoToWebinar control panel, where you can hear the audio of this webinar through selecting your computer's microphone and speaker or telephone. And there is also the chat area where you can submit questions throughout the presentation. At the end of the presentation, we'll have a Q&A session. And I will read your questions you submit to our presenter. And I'd also like to note that our webinar is being recorded and will be posted on our YouTube channel for viewing afterwards. Today we are pleased to bring you Dr. Michael Hogan. Dr. Hogan served as New York State Commissioner of Mental Health from 2007 to 2012 and now operates a consulting practice in health and behavioral health care. The New York State Office of Mental Health operated 23 accredited psychiatric hospitals and oversaw New York's $5 billion public mental health system, serving 650,000 individuals annually. Previously, Dr. Hogan served as Director of Ohio Department of Mental Health and Commissioner of the Connecticut Department of Mental Health. His awards for national leadership include recognitions by the National Governors Association, the National Alliance on Mental Illness, the Campaign for Mental Health Reform, the American College of Mental Health Administration, and the American Psychiatric Association. Dr. Hogan is a graduate of Cornell University, earned a MS degree from the State University College in Brockport, New York, and a PhD from Syracuse University. Today, Dr. Hogan will discuss why integration is important for states to pursue and what key components states should consider. Welcome, Dr. Hogan, and thank you for your presentation today. I'm going to pass the screen control over to you.
Great. Thanks, Emma, for the introduction, and for everybody who's listening in and watching. Thank you for spending some time with us here. As Emma will have said, from the introduction, I'm obviously a guy who has spent most of his time in state government and in what I call, with reference to mental health care, the deep end of the pool, that is thinking about the specialty mental health system. But a lot of my work now is focused on integration, and within integration, focused on primary care. And I hope the reasons for that become obvious. Emma and her colleagues asked me to talk a little bit about, as it says here, the rationale for integrated care and the state policy enablers. There are probably not any state government people who are listening in and are just looking for that one little answer that will tell them how to magically change financing to enable all this, and at the end of the presentation will immediately rush out to do that. Although in a sense that's the target. But what I'm going to run through is the background, because I think why it's important for us to do this is important. A little bit about how to do it and some of the challenges. I'm going to focus primarily on primary care, but talk a little bit about what might be described as reverse integration, and that is general medical care in behavioral health settings, and then end up with some things about what it takes to do this and what states can do to, or other payers for that matter, to make it happen. And I'll say at the outset that primarily when I'm talking about integrated care, I'm using sort of a simplistic definition of integrated care as being care for mental health and addiction and other conditions, common conditions, or what might be described as basic or primary care kinds of conditions, that is delivered in one setting, preferably off an integrated treatment plan in a clinical team approach. There are we could go a lot deeper with that, and indeed I will, but that's what I'm talking about, or what I mean by integrated care. I think first, at a very high level, integrated care is just common sense. People prefer it. We know that more people with mental health problems get something from their primary care setting than the total number of people who get anything from all specialty mental health settings put together. And that's partly because of stigma, and that's partly because that's where people go to talk about health problems, and it's partly because we don't have the capacity in many places, particularly absent things like Proposition 63, which years after it's passed remains unique in the country. And so in many places you can't get into mental health settings anyway. So integrated care is common sense. We now know that an awful lot of people are dealing with, in a sense, both sets of problems. And when you're dealing with both sets of problems, if they're being treated, sequentially, or only one of them is being treated, each will tend to make the other worse. So that disintegrated care is expensive and ineffective, and is bad for your health, as well as for healthcare spending. This is just another illustration of this from epidemiological studies, that we see that about a quarter of the adult population, the numbers are not that different for young people, would experience a diagnosable mental disorder in any given year, whereas about almost 60% of the adult population would have some medical condition during a year. But this focuses on the overlap, and that is to say that most adults with a mental health problem have got some medical condition that periodically needs attention, and a significant proportion of adults with medical conditions also have mental disorders, and that percentage rises for people that are dealing with chronic illness, or particularly with multiple illnesses. So in a sense, we're really focusing in on that overlapping part of the Venn diagram. this is another description of why integrated care makes sense that goes to a very basic level. This is from Wayne Caton's work. And Dr. Caton here really has put into a diagram what we understand from the adverse childhood experiences study and other sources that tell us that risk factors, many of which might be viewed as behavioral, in fact lead to adverse health behaviors and then chronic medical conditions. So we don't usually think of it this way, that behavioral challenges end up putting people in poor medical health, but this is true. And since dealing with chronic illness requires behavior change, that's just another reason for a behaviorally competent approach, to say nothing of actually integrating care. But there are other reasons why integrating care is important. There is pressure now under the Affordable Care Act and explicit requirements in Medicare to try to reduce readmissions. And this just is a little analysis that we did in New York a couple of years ago. So this is New York State Medicaid data showing all people who had a 30-day readmission to a hospital in New York. And what this shows is that the percentage of people with a readmission who had a readmission for straight medical reasons and did not have a behavioral diagnosis was actually a very small piece of the pie, less than 20%. About twice that, about 40%, excuse me, was behavioral readmissions. That's a detox readmission or somebody who had been admitted for psychiatric care and was readmitted within 30 days. So it was a behavioral readmission. So that's more than the medical readmissions, but still both of these categories pale with respect to the people who were readmitted for medical reasons, treatment of their medical condition, but we know that they had a mental health or substance abuse diagnosis. Either the diagnosis was in the claim or there was a claims history of treatment for these conditions. So viewed in this way, we see that 80% almost of all hospital readmissions may have involved some kind of behavioral health issue. So from a point of view of cost control, this is pretty important. This is another view, an economic view of why integrated care is essential. This is data analyzed by Roger Cathal, who is a psychiatrist and a internal medicine doc, who now consults in this in this area. You see his company Cartesian Solutions, and this was a large data set of people in health plans in the Midwest, and the data just looks at the different medical conditions that people might have had over on the left, the cost of caring for people with that condition, the percentage of the people in the plan who had this condition, the percentage of individuals with this condition, like arthritis, who had a co-occurring mental illness, the total cost of care, that is for both mental health and behavioral and medical problems for these individuals, and then finally over here, the cost increase that is attributable to the mental illness, that is the increase for the people with the co-occurring mental illness over the straight medical condition. So what you see is substantial portions of people with a chronic medical illness who have a co-occurring mental illness, most frequently depression, but also anxiety disorders and other conditions. And then we see over here the very dramatic cost increases that are attributable to this. Now, clearly, a portion of this cost increase could be for treatment of the mental health problem, but what is telling from the previous slide is a lot of this cost increase is attributable to a bad adherence to a diet or exercise or treatment requirements, or bad, if you will, self-management, leading to medical problems in both emergency department and inpatient visits. Here's another reason why integrated care is essential, and that's because it's hard to get into especially mental health care. The sector has been underfunded for years. State budget cuts have made it worse, and so here you have a cartoon that originally appeared in Health Affairs. The guy is out on the ledge, and the cop is saying to him, "We couldn't get a psychiatrist, but maybe you'd like to talk about your skin. We've been able to find a dermatologist here." And in study after study, or survey after survey, internal medicine, family practice, pediatrics, basic primary care physicians report worse access to mental health specialty care than any other brand of or category of specialty care. So that's not very helpful. The final reason why I would argue that integration is important is not just that it's good for people and not just that it's good for health spending, but I believe business imperatives are going to drive it, particularly following these two pieces of legislation, Domenici-Wellstone, or the Mental Health Equity and Addictions Parity Act, and then the Patient Protection and Affordable Care Act, with the parity coming first, and then the Affordable Care Act, which is a significant sequence because it meant that parity was built into the requirements of the Affordable Care Act. And so here's just a quick listing of business imperatives from my point of view. The first of these is that the ACA explicitly emphasizes integrated care arrangements and gradually introduces incentives and requirements. These are some examples of that. Medicaid health homes, about which I'll say a little bit more, ACOs, patient-centered medical homes, and finally penalties for readmission, all ought to encourage participation in integrated care. We don't know yet, unless something has happened in the last couple of weeks. We still haven't seen the HHS parity regulation, but a rumor is that the HHS parity regulation, when it comes out, may encourage benefit integration and discourage the use of carve-out. In other words, an insurer or an employer creating a different benefit with a different network for management of and care of behavioral health problems, which in the past has been a very rational thing to do because it's been a different set of providers, because behavior is a little bit different with respect to insurance. For example, we have evidence that says if you make psychotherapy completely free, people will use too much of it, which is scarcely a surprise. And that's more of a problem than if you made visits to your PCP completely free. That would be a problem too, but not nearly as much of one. So appropriately balancing access and affordability is a little different in the behavioral health world. People are less likely to go initially, and then under limited circumstances, they may go too much. And so benefit integration may be a part of the parity regulations. As the mental health system has gone from a completely separate standalone system, originally just state hospitals, and then community mental health centers, and now in some states, like California, I don't think there's even a standalone cabinet level mental health agency anymore. As this moves into the mainstream, purchasers are starting to cover or discover this problem of costs that are associated with people who are medically ill but have behavioral health conditions. I always think of my mom, who had diabetes and depression, when she was managing her depression, she would take care of her diabetes. When she stopped managing her depression, she would not manage her diabetes, and we'd have all kinds of problems. And that's just one example. One of the big things about healthcare reform, the Affordable Care Act, is that many more people are going to have coverage, although some states are still waffling on the Medicaid expansion. But whether it's via Medicaid expansion or under the exchanges, they're going to get coverage. And we know that the prevalence of behavioral problems among the people who will have health insurance for the first time is pretty high. Many of those people have not gotten any care. If they are dealing with a very, very serious mental health problem like schizophrenia or active bipolar disorder, they're probably engaged in care. At least there's a 50-50 chance that they're engaged in care. But if they've been suffering silently with depression or anxiety or even mild psychotic illness, they may have gotten no care whatsoever, partly because of cost. They're going to have insurance for that now. And the question is where they're going to go. They might come to the mental health center to try to get in, but they may very well, if they do, be told that their problem is not that serious. They should come back when it gets worse. We don't put it like that, but that's what it sounds like. And so primary care, I think, is going to be where people seek or show up with behavioral health as well as medical challenges. And my last bullet here is really the kicker, and that is that purchasers love managed care, and everything else is a detail. Because if the purchasers love it, they're going to do it. And purchasers love managed care for several reasons that are relevant here. One is if a state Medicaid director contracts with managed care firms to manage care, they have shifted the risk of overspending to that entity, guaranteeing that they're not going to have to go back and face an angry legislature. And that's a pretty big incentive, even before you get to issues of quality. So the managed care is going to grow, and increasingly the trend is going to be to integrate behavioral health and healthcare conditions. So all of that are the set of reasons why I think this is inevitable. And it leads me to my next little chapter here, which is where integration is important. And the most important place for integration is in different versions of primary care, in health centers, in medical homes, in FQHCs, which to some extent are well integrated now, as the VA clinics are. But there's still a lot of primary care settings that don't have competent behavioral health care yet. This is just a different version of a chart showing where people get care, showing that most people with a mental disorder get no care at all. Of those who do, more get it in the general medical sector than from a mental health professional. But the problem is that routine, not adapted mental health care in primary care is not so very good. One estimate, this is also from Ron Kessler from the update to the National Comorbidity Study, is that when you get through the half of people with depression who don't get a diagnosis, and then you get to the percentage who get a diagnosis who get care at all, Dr. Kessler's estimate is that 1 of 8 people with depression who are in routine primary care get minimally adequate care. Minimally adequate care is just defined as enough treatment so that the kind of the treatment and its dosage, if you will, is likely to make a difference. That is, at least 6 or 8 or 10 sessions of psychotherapy, which people are extremely unlikely to get in primary care, or an adequate course of a medication treatment like an SSRI for depression that is going to not just make you feel a little better, but achieve a significant relief from the symptoms of depression. And absent genuine and thoughtful approaches to integrate care, we see that, in fact, a lot of what's going on in primary care just is not up to snuff. Here's another illustration from the original National Comorbidity Study in the early 90s to the update in the early part of the last decade. The National Comorbidity Study is a detailed phone interview with about 9,000 people that includes asking them about their health history, but it also includes a simplified diagnostic interview schedule that is built into the conversation with the person. So it allows a pretty accurate imputed diagnosis. So what we see over this period is, first of all, this trend that the percentage of people with a mental illness who got care jumped pretty dramatically between the early 90s and the early aughts or double zeros, or part of the last decade, or whatever you wish. So the question is, how come we had this dramatic increase in mental health treatment during this period of time? Certainly in Ohio, where I was at this time, we weren't getting these kind of increases in the mental health budget. And the answer to why and how people got this increased treatment is relatively simple, and it's basically Prozac. I mean, not just Prozac, but Prozac and Zoloft and the other SSRIs that were medications that were not necessarily more clinically effective than the older medication treatments, but were much easier to be prescribed in primary care and other settings, OBGYN, et cetera, because they're less chance of overdose. Dosage is not as complicated. Plus, there were all those direct-to-consumer advertisements that were going on, making people say, you know, Doc, I've been thinking about this. Do I have to feel this way? So what you see in the box at the bottom here is that in the early part of this last decade, as those medications started to go off patent and as the direct-to-consumer advertising went away, the percentage of people getting adequate care for depression, in fact, was reduced. Mark Olfson at Columbia has done some analysis that suggests that the modal experience of people who were talking to their GP about depression was to talk about it, to get one prescription for an SSRI, no psychotherapy, and for that prescription to not be renewed. In other words, the people would take it, would maybe just start to feel a little bit better, or would maybe, you know, sort of give up on it and wouldn't understand that it's going to take a while for the effectiveness of the treatment to kick in. So it takes more than just screening or just writing a prescription to deliver adequate integrated care. So this is just some more data on this. We know that good integrated treatment is effective in clinical trials that combine psychotherapy and medication treatment. 75 to 80% of individuals improve. And in routine practice with mental health specialists, the rates approach that. That is, about half of people have significant clinical improvement. So the question is, what does it take to deliver comparable or good enough behavioral health care in primary care? And here I steal a slide from Dr. Jürgen Unitzer at the University of Washington, one of the developers and testers of the collaborative care approach. And so you can't just do one thing. You can't just screen. You can't just train. You can't just write scripts. There are a few things that have to be done. First of all, the physician or nurse practitioner has got to have a behavioral health person on the floor, not across town, not in another building, but on the floor to be able to see people quickly and to provide support. The practice is going to have to be trained somewhat in what it takes to do this kind of work. There should be caseload-focused psych consultation that's available. It might not be Jurgen, as is seen in this picture, but some psychiatrist that the behavioral health practitioner, whether that's a psych nurse or a social worker or a psychologist, but more likely that the primary care physician can call up doctor to doctor to say, I'm trying this and it's not working, and what do you suggest? Or maybe to say, we've tried everything we can do at this level and I need to make a referral to you. A critical element of this approach is measurement-based or stepped care. So a PHQ or some instrument is administered when the patient comes in, so you can just check whether progress is being made. If progress is being made, great, keep it up. If progress isn't being made, trying something else. Educating and informing the patient, which is what one of the things the behavioral health person should do. And in general, we see that integrated care is going to require these practice supports. So it ain't real easy to do this, although it's very important to get it done. It's just an illustration of a stepped care algorithm from the Ames Center at the University of Washington, one of the elements of this. And just a couple slides about the impact of care. So here's one of the studies of impact, one of the original clinical trials of this kind of quality integrated care in 8 different organizations, and what you can see is the percentage of patients who experience 50% or greater improvement in their depression systems over 12 months. So now different pattern in different in settings, but overall a 50% or greater improvement in depression. And if you look at the levels of improvement that are seen, what you have is about half of the patients achieving 50% or greater improvement in their depression symptoms, which is about the same thing you get in a specialty mental health service that is delivering high quality care. So it's effective. Interestingly, it leads to better physical function. So this original trial was with elderly patients with depression, so more likely to have other medical complaints or issues. And what I infer from this is not feeling depressed helps people take better care of themselves overall. And this is a final complicated little chart. This shows the cost of integrated care. And what you see is different categories of cost. This is what the impact program costs on a per patient basis. So here you have an increased cost of delivering the integrated care only for the trial group. There was obviously no increased cost for the control group. They didn't do it. Then you have these categories of overall healthcare cost, and what you see is for every one of these categories, for integrated care, the cost goes down. It goes down below the control group. It's down below the cost of usual care, which not surprisingly looks kind of like the control group. And so what you have overall is a significant reduction in costs for collaborative care, despite the upfront investment that has to be made. So it's really become time for us to figure out how to get this done. There have now been 79 research studies around the world with collaborative care, one version or another, one population group or another. We have few health interventions that are as well tested and proven. So before I go a little bit to the enablers, I'm going to talk just a little bit about integration in community behavioral health care, what I described in a sense before as reverse integration. We know that many people who rely on mental health centers or other community mental health programs are in poor overall health. Everybody by now has heard the data from the one line from the report done by the medical directors of the from NASHBID that there's an average 25 years of life lost for people receiving care in the public mental health system. A little bit of that is suicide, where rates are unacceptably high, but most of that is cardiac illness and other medical problems. They get very poor access to care. This has been pretty well documented. They may not be welcome. If they get into the waiting room, they may not feel comfortable staying. They may not get the support that they need. They have lower access to every kind of specialty care, from routine interventions to transplants. It's not a pretty picture. And so if we work in that specialty sector, it's our obligation to step up on this dimension as well. This is one of the studies that that helped lead to all that, and I put this up here not so much because of the data, which is pretty striking. This is just data for different age groups looking at the risk of death or rates of death from heart disease for people in the Massachusetts public mental health system. That's the red for each age group, coupled with overall death rates in Massachusetts. So what you see are these dramatic differences. Here in a population in their late 30s, early 40s, we have a 5 times higher rate of dying from heart disease for people receiving mental health care. This study was done by Ken Duckworth, who at the time was providing care in a mental health center, the Massachusetts Mental Health Center, and Ken got upset on finding that patients were dying and nobody was celebrating their deaths, and he started organizing memorial services. And after doing a few of these, somebody came up and said, "Dr. Duckworth, your memorial services are so wonderful." And he realized, oh my God, there've been a lot of them, and that led to this study. Without going deeply on this, I would say that there's one thing that should be done to integrate care in the community mental health arena. There are many things that could be done, but the best opportunity is this Section 2703 Medicaid health home that some of the states are deeply involved in. It allows an enhanced federal matching rate, not for all care, but for coordinative care for the first 2 years in a program that where individuals have mental health conditions, substance use problems, or a range of different chronic medical conditions. But interestingly, the feds don't do this very often, but this is set up so that individuals with serious mental illness that is treated as an area in such need of coordination that people are eligible. For those who are interested, I would really commend attention to what I think is the best developed of these programs, which is in the state of Missouri, where they've got great information on their web. Different states are approaching this in different ways. New York has got not atypically a sort of a muddled strategy. Missouri and Ohio have as a priority for their health homes bringing qualifying or interested mental health centers up to speed to be able to provide fully integrated care. So I'm turning now to some of the challenges in doing this work, and then I'll close with a couple of thoughts about what states can do. There are pretty clearly both internal and external challenges to the work of integration. The biggest of those is just that lots of cheese is going to get moved, with a reference to that "Who Moved My Cheese" book. This upsets everybody's routine. The patient is not just the PCP's patient anymore. It's also the social worker's patient. The culture and pace of behavioral health care is different. We tend to move slower. We have the 50-minute hour instead of the 6-minute visit. The charting is different. The conventions are different. The rules may even be different with respect to privacy. Different patterns of workflow. How do we actually integrate care in the EMR? It's a different kind of work, and finding behavioral health professionals that are comfortable in that setting, or vice versa, is a challenge. And just finally, change is just a bear. It's easy to recommend and very difficult to go through. And having a chance to be able to observe some places that are working on this. Many are achieving great results, but this is a difficult strategy to pick up on. But it's not just the internal problems that are faced. There are a range of things that make it more difficult to do integration in the policy and regulatory environment. We have regulatory factors, for example, licensure, and here I'm not speaking about individual practitioner license, but licenses that are given out in many states for providers to operate a behavioral health or a healthcare service. If you're a public clinic, the conditions of those licensures, one of the barriers we found in New York, honest to God, was a requirement, and we found this out when we were just trying to integrate addiction and mental health care, where our licensure requirement required different waiting rooms and different places, in some cases different restrooms, completely a bozo. So these regulatory factors can make a difference. And then there are all kinds of financing challengers. Now, one of those that's a legacy issue is that the carve-out insurance contracts that I've talked about before, generally if you got a provider network set up to deliver specialty mental health care, and you go to a separate insurance plan to get your medical care, members of one are not going to be members of the other. So that the carve-out basically precludes the provision of integrated care in one of those settings, because there are different network requirements, different documentation requirements, et cetera, et cetera. There may be critical elements of the integrated care service that are not covered. Medicare is a good example of this. So Medicare has been upgraded, so now people can get a psychotherapy visit or contact during the same on the same day or in the same visit, where they're also seeing a doc, but you can't get paid into Medicaid for the consultation time of the psychiatrist, and most insurance plans don't cover that. And then we get deeper into the weeds on who has access to which billing codes. These the one visit per day limitation, which is complicated and obnoxious and unnecessary. And then finally, that every payer has got a different approach, which codes they cover, to whom, who's in the plan, et cetera, et cetera. This is difficult work under the best of circumstances, and these challenges make it all but impossible. So I start to close here with my wish list for what states would do to support integrated care at the community level. The first is to care about it, and I don't say this with any irony. State leadership ought to be talking this up and pushing on it and telling people that they support it and being engaged in dialogues. The state should take steps to eliminate regulatory barriers, and I have an example here from New York, which is easy because New York tends to overregulate everything. I gave that one example. And a second example, right now the Department of Health in New York licenses medical clinics, mental health licenses, mental health clinics, and the state agency for addictions licenses addiction programs. And if you're a medical clinic that wants to provide mental health services, you got to first have the health license and then go to mental health and apply for a separate license. This is bozo. So the state agencies are working on an approach where a clinic licensed under any one state agency can apply to that same agency for an add-on to their license that would allow them to deliver the other services, in which case that agency, for example, the Department of Health, would apply only those additional requirements for mental health, basically related to staffing and so on, in order for that agency, the community agency, to then deliver that service, under which, when the licensed extension was granted, they then have access to those billing codes. That's just one example. I think a really important challenge is going to be to integrate benefits. This is particularly important in the startup of the insurance exchanges, although it's unlikely to be done in many settings just because there's so much pressure on the exchanges. But I hope over time the exchanges move to an integrated benefit that is adequate for both the provision of the basic care, whatever it is, medical care or mental health care, but facilitates whole person care in a single setting. We've got a lot of work to do to protect the essential behavioral health safety net while all this goes forward. Unfortunately, there are a few states that, like California, have got this protected and dedicated resource stream. So that's an important mission, but to some extent that separateness at the insurance plan level, particularly for new entrants, is an obstacle to integration. And a lot of the challenges have to do with figuring out how to pay for it. The ability to not think of every session as a visit, but to do what's done within primary care right now, where you go in, you might get an exam, you might get an x-ray, you might get a blood draw, you might get a little behavioral counseling. These are all treated not as individual visits, but they're treated as procedure codes within a visit, and then the bill adds all those things up. Maybe it discounts a little bit for things done under the same day, but we've got to allow multiple procedures, including behavioral health and mental health kinds of activities in one visit. And then working out the codes, making codes available for psychiatric consultation. The Medicaid Health Home option is one very promising approach in that regard. And one of the things that is exciting but frustrating for those that are watching this is the new models for financing integrated care that are underway in some of the states. Massachusetts Medicaid has got a program they're just entering into for their fee-for-service primary care practices, where they're going to pay a little bit of a case management fee, but they're also going to allow those practices to decide how much risk and responsibility they want to take on for addressing behavioral problems in their patients and pay them accordingly. So I hope they succeed with that and that we learn from it. And then the states like Colorado and Oregon that are trying to think this through under their SIM grants from CMS really offer, I hope, the best prospects of good solution. It would be nice if states could facilitate technical assistance on how to do this right now, and I think my last slide, which is the next one, has a few resource options. If you're interested in doing this, it'd be nice if states could support that. And if it were a perfect world, states would help with things like EMR implementation or the costs of conversion. Although that reminds me of a comment from a therapist friend of mine, which is that it's okay to want that. But in a perfect world, we would see that as well. Here are some resources for integrating care, just some websites. The AIM Center at the University of Washington, the Advancing Care Together initiative in Colorado, which is a wonderful little program that I'm happy to be a cheerleader for. The AHRQ AHRQ has got an academy for integrating behavioral health and primary care, and there are resources that are starting to go up on that website. And finally, the SAMHSA HRSA Center for Integrated Health Solutions, which focuses on integrated care across the board, but focuses more than these others on what I've described before as reverse integration, and includes resources on, for example, billing codes in different states to actually do this work in the state Medicaid program. So with that, I've gone over a few minutes, and I'm going to end with good luck to everybody and turn this back to Emma, who may have some advice for you, or may take your questions and pass them on to me, and we'll see if I can respond to them.
Great, thank you so much. That was wonderful. If you would like to submit your questions through the chat, we will just go through each one submitted. So our first question, well, we have a comment and then a question. Another important issue concerns the negative attitudes primary care physicians carry towards patients with mental illness. An important piece of these negative attitudes come from lack of training. This dilemma was captured beautifully in a recent first-person Sundat review piece in the New York Times, When Doctors Discriminate, by Julian Gary. So the question for you, Dr. Hogan, what are the best teaching strategies to counter these negative attitudes?
Yeah, I was going to mention that that terrific little first-person commentary, and then there were some good responses to that, mostly from clinicians. The commentary, as I recall, was written by a person obviously exceptionally well educated and competent with bipolar disorder, who basically went to, I think, an ED needing some treatment and was told, "You're on too many other meds, I can't help you." Just ridiculous. I do think that that some people are up to this challenge and others are not. It's said that the docs coming out of primary care training right now, for example, I've heard that the University of Washington, which has got a track specifically for training in integrated settings, that people are coming out of that and saying, I don't want to work in any place other than, and that just as younger docs are going to be much more apt to be able to be conversant with electronic charting and so on. For those of us that are out there and are ancient and are set in our ways, I just wouldn't go there, was my response. And I do think that the pressures are such that over time this is going to hopefully change and discrimination will wane. I do think that one of the reasons for this, and those of us in the mental health world to some extent have to look in the mirror on this, not that it's our fault, but that having a separate set of settings for mental health care is one of the things probably that reinforces stigma. So I think that doing integrated care is the best thing that's going to address this over time.
Thank you. Are there any other questions from our participants? You can either type in the chat box and I can read it out loud, or you can raise your little hand in the GoToWebinar control panel and I can unmute you if you prefer to ask that way. Right, another question for you, Dr. Hogan. Which state is leading best by example on their integration efforts, in your opinion?
That's a really good question. Well, I don't know everything that's going on for sure. The only thing I'm pretty sure of is that I think, as I said, Missouri's approach to integrating medical care into their behavioral health system, I think, is heads and shoulders ahead of everybody else's. The places that there aren't a lot of states that are, I think, effectively and comprehensively leading on integrating basic behavioral care into primary care. Now, as I said, the VA does that in its clinics. The FQHC program varies, but certainly newer uh, uh, community health centers tend to emphasize integration. So those are two strong points. There are places that are supporting this, like, in fact, family practice at the University of Colorado or the Ames Center at Washington, that tend to have sort of infected their communities. So I've been very impressed with what I see going on in Colorado, and the Health Foundation has also played a role in that. I don't know whether state government is leading or following in that environment. But there certainly is a lot going on in Colorado. There's a lot going on in Washington, and I'm probably neglecting other people that are doing great work only because I'm not aware of it.
Thank you. And we have another comment. I think it's crucial that primary care doctors get help with behavioral health and not asked to take it all on, i.e., substance abuse, significant mental health issues. They are hosed, if you will, with everything they are currently required to do for their patients.
I'm really glad that that point was made, because, and I hope that my approach to this doesn't override the work that is being done, because the primary care is already on overload. I guess that since the patients are already there by and large, I think it's very important for us to do this adaptation. But strategies, and I think the evidence proves this, strategies that suggest that primary care can do this if just they cared more, or they could do it on their own if they just start doing screening and so on, are just wrong. Um, the dynamics of behavioral health care are a little different, which is why I think that a critical first enabler, if somebody's going to get into this, is to figure out how to get a behavioral health person in the practice to be able to work with the rest of the team, and then for the practice to figure out which kinds of problems can we take care of and address well ourselves, whether it's just through the work of the PCP, whether it's through the work of the behavioral health provider or care manager. But you've got to have backup help for this as well. So I really appreciate that the point is it's made. I think it's absolutely true. This work has got to get done, but it's not going to get done by dumping on primary care. I think of pediatrics as an area where, in many cases, that's the case right now. Pediatrics practices are just slammed. They see more kids with behavioral health problems than any other single diagnostic category, and they don't have the help, and the cavalry is not coming.
Great. Well, thank you again, Dr. Hogan, for your presentation today, and thank you to all of our participants for joining us. Our next webinar will be held on Friday, September 20th at 1 p.m. Eastern Time on the topic of statewide integration efforts in practice and policy, perspectives from Kentucky, Pennsylvania, and Texas. Thank you very much.